Thank you, Dr. Rashidul Hassan. I'm very happy to speak on gonioscopy in the webinar organized by Bangladesh Glaucoma Society. I'd like to thank Bangladesh Glaucoma Society for the opportunity. You know that gonioscopy is very important subject because in the diagnosis and therapeutic and angle surgery, we need gonioscopy nowadays. I do not have any financial disclosure. Now the question is, what is gonioscopy? It is a clinical biomicroscopic technique to examine the anterior chamber of the eye with a contact lens called gonioscope. And not only for the diagnosis, it's also important therapeutically for giving laser in the eye and also the angle surgery, especially minimally invasive glaucoma surgery nowadays. So you can, it's a very 1 minute clinical video that I do in my office every day, many times. So first of all, it's very important to hold it, and you can see in the monitor, you will connect to the camera, the angle here. You can show it to your residents and students and other staffs. Now the indication why we do gonioscopy. Most important is to diagnose glaucoma. Is it open angle or close angle, or any secondarily any changes in the pathology in the angle or not? Before dilating any case, we must know the angle is occludable or not. Any glaucoma suspect patient, any glaucoma patient, we should do gonioscopy. In the Van Herrick method, if it is less than 2, grade 2, then definitely we have to do gonioscopy. Any history of trauma, long-term diabetes, neovascularization, pseudoexfoliation, pigment dispersion, and rule of secondary causes, we need to do gonioscopy. And for the laser treatment, of course, we need also for the lingual-based surgery, we need gonioscopy. There is a study and article by Dr. Stephen Bold and Dr. Aik Ahmed. And they found that gonioscopy started actually more than 100 years before by Greek ophthalmologist Alexios Tarantos. And he examined the keratoglobus and done gonioscopy. So Greek gonia means angle and scopin means to observe the angle. And after that, in 1914, Salzman introduced gonio lens. 1919, Copy designed improved steeper lenses, and many surgeons had improved a lot. And 1966, Forbes described the indentation gonioscopy by Zeiss Former gonio lenses. And now recently, there are many improvements of the gonio, especially the surgical gonio lens. And these are direct gonio lens, and it can be, sometimes you have to incline the patient and rotating the microscope. But with this direct view gonioscope, you can do the surgery directly. Similarly, Ocular Ahmed by Aik Ahmed designed this Ocular Ahmed with extreme wide field lens. Then Ocular upright 1.3 times surgical gonioprism by Ocular. So these are the recent invention and recent improvement. And very recently, Dr. Aik Ahmed published a report using a gonio ready. That means it is the gonio lens that is connected or fitted with the microscope. So you don't have to hold it by another hand. So surgeon can use both their hands during the surgery, and that becomes very easy and more perfect. So this is also an improvement of gonioscopy. Now, I mean, what structure actually we want to see in the angle? We'll come later, but in detail. But just to know that 4 structures very important: Sosby line, trabecular meshwork, sclera part, and ciliary body band. It's very important. If you look to the anatomy, this is the cornea, this is the sclera. So in the cornea, termination of the displaced membrane that produces Sosby line. And then there is the Slem's canal, and just roofing the Slem's canal in the internally, it is the trabecular meshwork, TM. So anterior 2/3 part is non-pigmented, and 1/3 is pigmented, functional part. And behind this, it is attached to the scleral spar. This is the most anterior part of the sclera. This is the spar. And this is the ciliary body band, ciliary body. So these 4 structures we have to search in the angle. One is Sosby line, second is the trabecular meshwork, third is scleral spar, and fourth is ciliary body band. But can we see the angle with a torchlight or slit lamp? No, because there is total internal reflection, because we know that refractive index of cornea is nearly 1.4 and division of air is 1. So when they go from one higher density to lower density, it bends totally the same side, a total internal reflection. So it can. But if you put a lens here with a similar refractive index like cornea, like 1.50 here, then the light ray can pass through the cornea and go to the mirror or to the lens, and you can see. So this is the optical principle of gonioscopy, and I think it's one of the question given the FCPS due examination, the optical principle of gonioscopy. So you have to write and draw the picture to understand, to explain the optical principle of gonioscopy. So with this principle, we can have two kind of lenses. One is direct lens and another indirect lens, indirect mirror. So direct lens, when the lens is put over the cornea, the view from the angle directly goes to the surgeon's eye. And when in the indirect mirror, and the view go to this mirror, and from here, the surgeon can see. So it's the opposite angle, of this the person. This is the opposite angle or opposite side. So the question is how to learn gonioscopy. Gonioscopy is a highly subjective technique and requiring extensive practice and experience. So I always say it is a practice, and practice to make you perfect for gonioscopy. There's a book picture by American Academy of Ophthalmology, section 10. We find the schematic diagram of gonioscopy. You see here, from here, if you see, this is the reflection of outer cornea, reflection of the inner cornea. They meet in a point which is called the corneal wedge. In this meeting point, line is the Solvis line. So in practice, it's not very clear like this, but still it is possible if you can make it. I'll come later. And then the bigger part is the trabecular meshwork. And this trabecular mesh is non-pigmented. This 1/3 is pigmented. And just behind it is the very whitish band, is the sclera part. And just behind it is the ciliary body band, then root of the iris. So this 5 structures is very easily seen. And if you can master, if you have in your mind, definitely you can search in the real or living eye. So diagnoscopy is done by lenses, copy lens, Barkan, Swan-Jacob. You can see directly, mostly using the glaucoma angle surgery and like Schlem's, like in the eye stent inject and goniotomy, etc. So these are few example of copy lens, copy modified lens, the Barkan lens, and this is Swan-Jacob lens. And this Swan-Jacob type of lens is very useful for the angle surgery. Most of the surgeons now, though there's many direct view lenses, but use the Swan-Jacob type of lenses. And you can see I'm doing a mixed bang surgery here, and you can see directly. You can see very nicely. You see the angle here. This is the angle. So this is the trabecular meshwork, and this is the sclera part, and outer is the Solvis line. So just if you look here, the root of the iris, ciliary body band, then sclera part, then trabecular meshwork, then it's easy for you to do any surgery in the angle. So in indirect gonioscopy, we have to understand that though it is opposite angle, but orientation of left right is same. Just like this, if you see here, the mirror at the 12 o'clock, we are looking or examining the angle of the 6 o'clock. Same time, here is the angle of 5 o'clock, here is the angle of 7 o'clock. So the right-left orientation is same, but in the opposite direction. If we examine in the 11 o'clock, that mirror is in the 11 o'clock, we're examining the 5 o'clock position of the eye. Similarly, 4 right side, 6 other side. So 4, 5, 6 like this. 4, 5, 6. So lateral orientation is same, though it is opposite. Well, indirect gonioscopy again is of 2 types lenses are used. One is scleral type, the Goldman lenses, like Goldman lens, and as a corneal type, like the Zeiss lenses. So these are the example of scleral lenses, the single mirror, double mirror, triple mirror. And actually, advantage of this lens are good many because it gives excellent optics. Lens stabilizes the globe, easy to examine, and permits examination even in a non-competent patient. And for the learner, students, the residents, it is the lenses can still use earlier because you can see better. You can see better. Before using the 4 mirror, you can use the 1 mirror, 2 mirror, or 3 mirror lenses. These are some improved lenses of 1 mirror, like the Magna View lens. These are lenses actually used for the laser. And you can see that if you use this kind of lenses, like I'm using here, for the selective laser trabeculoplasty. And even I have seen, even my student who has not seen the gonio before, they can see very clearly. So this is the lens that you can teach these students. You can see here, so nice that very nicely you can see the ischial part, and very nicely you can see the trabecular mesh. So I am to put the laser here in the trabecular mesh. So you can see that is very easily I can put the trabecular mesh laser in the trabecular mesh. So this is the lens, the Latina lens I'm using it. It comes with the laser machine and very expensive, though it's expensive, but it is very easy and very and nicely visible, the trabecular mesh, and it's good for the surgeon to do the laser here. You can see there is some pigmentation in the Solvis line. It's not the trabecular mesh, so should not be confused. Sometimes even there is more pigment, we could call it symbolosis line. It's not symbolosis, but pigmentation here. Well, what are the lenses we use? There are many lenses, many kind of lenses, but most commonly they use the Zeiss, Foster, and Sussman. These three lenses, some with handle, some without handle. Many surgeons prefer handle, many surgeons prefer without handle. So it's personal choice. So what is the advantage of 4 mirrors? It is a 64-degree tilt and 90-degree away from each other. All 4 angles can be seen in same setting. No coupling foot is required because area of central corneal contact lens is smaller than the corneal diameter. And indentation gonioscope is only possible by this 4-mirror corneal type of lenses. And definitely it needs a lot of practice with higher magnification. And whenever you are oriented with this, definitely the surgeon use only the 4-mirror. We do not need the single mirror. So advantage already I mentioned. Another advantage is the rapid and comfortable exhibition patient and rapid transfer from one eye to another eye. As you are not using any gel, so patient is more comfortable. And there's no suction adherence between the cornea and lens. It's difficult to open, it's not that. And endoscopy is the most important advantage to understand the patient is having occludable angle, then is it a position angle or cynical angle closure. So it's very important technique how to do indentation. First of all, I will show the technique, but just a brief few points that just touch the cornea and see the iris. Do not pressure. When you see the angle is open, it's fine. If it's not open, then of course you give pressure and try to see if the angle structure are visible or not. If the structure are visible, that means it was a positional closure. If not visible, it was cynical closure. So when I find this case is occludable angle, I cannot see clearly the trabecular mesh or the ischial part. So it is occludable. Then I am giving pressure, and you give say some pressure on indentation, and there's indentation. I can see this ischial part. I can see this trabecular mesh. I can see this ischial part. So this is the indentation gonioscopy that gives you the difference between the cynical closure and the positional closure. The other type of gonioscopy called manipulative gonioscopy. What is that? Sometimes if the iris is convex here, like this, you cannot see the angle. But in that case, if you remove the mirror or lens towards the angle, or the patient looks opposite side, then you can see the angle like this. So this is, and the angle is open. So this is called the manipulative gonioscopy. Even you can do it by, or overhead view, you can do it by the single mirror lens also. So now coming to the point, how we do gonioscopy. I think each and every point here is very important. Number one is counseling. You must understand that it is something procedure. So if you put a lens inside the eye, the patient will be afraid. So explain the procedure to the patient, why you want to do it. Is open angle, closer, you have to do it. It's very important. Then make a narrow, bright, short slit beam. Do not put on the eye. They put on the forehead or somewhere. Select the gonioscopy lens. Use your elbow. It's very important. And forehead fixation, very important. Gently apply the lens to the cornea without compressing the cornea. Try to identify the corneal ways. I will come later about the ways and the Solvis line. If you do not identify Solvis line, go for the ischial part or trabecular meshwork. Assess which angle stacks are visible in each quadrant. So every quadrant you have to go and assess the level of iris insertion. The iris insertion is anterior or to the Solvis line, or behind the Solvis line or in the cornea is like that. Assess the contour of the iris just to exclude the plateau iris. If there is any double hump sign or sine wave sign, you should exclude it. Look for additional abnormalities of the angle. So these are the points that every point we should note when we want to examine. And finally, the four structures is the landmarks in the angle. One is Solvis line, there's the termination of displaced membrane, already we mentioned. Then tabular meshwork, which extends from Solvis line up to the sclera part. And sclera part is the anterior projection of the sclera, we showed, and appears a narrow whitish band. And fourth is the ciliary body band, just behind the sclera part as a pink, dull, brown, or slaty gray band. This is a very important slide to understand what is corneal OS. Corneal OS is very important to understand the Solvis line. But as you find here in the picture, it's not very easy in the practical, in the living eye, because the living eye, there is a lot of reflexes. So which one is the corneal reflex, which one is the internal, which one is the external corneal reflex is very difficult. But with practice, it can be visible. And another tip is that you can make a little bit offset of the ocular, like 20 degree towards nasally, then the reflex become less, and you can identify the external reflex from cornea and interface cornea. And these two reflex actually meet in a point. And this point is in the line. You see, this is the line. This is the Solvis line, the termination of the displaced membrane, this Solvis line. So this is very important to use very narrow, short slit beam and without a reflex, and very the light reflex should be less here. And if you can identify, it's very good. But if you cannot identify, go for the scratch part behind. That would be nice for you. So this is a corneal OS. You can see directly, you can see the Solvis line, and from there you can come to meshwork and the scratch part and root of the iris. But here you can see the corneal OS, but you cannot identify any structure. That means Solvis line I can see only. It's a closed angle. The angles are not visible beyond the corneal OS, convex and in the angle closure. And this is the open angle. So in the real life, real eye, it looks like this. So if you try, before going to the real life, let me show the picture. So first of all, you try Solvis line if you can make the corneal OS. And just behind it is the non-pigmented trabecular meshwork, then pigmented trabecular meshwork, then a sclera part, then ciliary body band. And from the iris to cornea, if you go, then start like this ciliary body band, then a sclera part, then pigmented part, then of the TM, then non-pigmented part of the TM, then Solvis line. So these are the four structures. Always you should keep in mind that I am to see. If you cannot see, if you cannot see the band, sclera part, then you can see the Solvis line. That means grade is 1. The patient angle is very narrow. And sometimes you can see in the angle, these are the lacy, delicate lacy fibers of the iris. These are actually iris process. These are physiological changes. And many patients we find in normal people, the iris process like this. It is usually confused with the peripheral synechia. But in pericyticea, it is broad and irregular. It's not everywhere present. It is mostly present. And it follows concavitive angle races like this, but makes a breeze over this, and does not obscure the underlying structures. You can see the structure. You can see the structure. You can see the trabecular meshwork. You see the sclera. But here it obscures the underlying structure, so broadband. Does not inhibit posterior movement of the iris on indentation. So you can indent it and does not move the posterior movement, but inhibits posterior movement. So it does not come back. So in the angle assessment, we have two questions to be answered. Is the angle occludable? And what else there in the angle? Other than normal structure, is there any pathological changes in the angle? We must find it out. When it is occludable, in English considered to be occludable if the pigmented TM is not visualized in more than 180 degree of the angle without indentation. So that is the occludable angle, and you should be careful about that. Now, before going to the actual living eye, let us show some normal picture of the angle, like it's an open angle. So you can see all the structure here, all the Solvis line, anterior and posterior TM, then sclera part, root of the iris, or ciliary body band. Here I cannot see the structure, only solvus line, so it is a closed angle. Here again, you can see a little bit pigmented part in the solvus line. This is the symphylosis line. And from there, if you come towards the eye, then this is the pigmented trabecular meshwork, and then is the stress part. But here you cannot see any angle. That's totally zero. Only cornea you can see. This is a closed angle. This is another example. Very nicely, you can see the stress part here, the trabecular meshwork, the non-pig, but this is the whitish area is solvus line. Here you can see the angle, but not very open, closed angle, and there is some patchy, blotchy pigments in the solvus line of the cornea. That means the patient might have took sometimes and actually touches the cornea, but it come back. So this is the blotchy pigments you can see here. Again, it's a very open angle, very much open. You can see the wide open angle here. You see the root of the iris, and very like the post-traumatic angulization. Here you can see the broad here, and other structures are also visible. In the closed angle, you can see the synechia, a lot of peripheral synechia here, and glossy pigments over the synechia and peripheral synechia. So this is the synechial closure here. So it is again the pigmentation over the solvus line. So what is that? Already I mentioned symphylosis line. And from there, you can see a little bit non-pigmented, pigmented part, stress part. Here again, you can see the angle is open. It was open, but now there are so many parts, and many parts is closed because of the peripheral antesynechiae. In peripheral antesynechiae. And some part is visible. Well, open angle up to ciliary body band here, but complete angle closure here. So now let us actually see how we should do it. It is done by one mirror lens here. So you see, I'm giving some KY jelly, the same kind of refractive index as cornea, a thick jelly. Now, ask the counseling the patient. I told patient what I'm going to do. I asked my assistant to room light off, make it darker. Then I hold upper lid, tell the patient to look up, then put the lens like this. So you can see it's very important to put the lens, then hold it with 2 fingers only here and other fingers on the forehead and your little finger touching here, mostly in the cheek or in the machine. Then you put the light, small straight light over the pupil. Do not go to the pupil. And then you can see here, after the only over the iris. So over the iris I can see, but this because of reflex I cannot see clearly. Then I made illumination less brighter, and then a little bit wider, so I can see a little better. Then you can see I can see it better. So I think you can see better now. Yes, this is the angle now I can see, and here you can see the trabecular stress part is very nicely seen. Then goes to the trabecular meshwork and then anterior part and solvus line. Let's see here. So this is the say this is the I'm looking superior mirror. So actually I'm seeing the inferior angle of this patient of this eye. Then I'll go to the other parts. I can rotate the mirror or I can go to the other part, and then you can see in this temporal side. So that means I'm showing the nasal angle of the patient. And you can see this is what is this? I think you can understand. This is the post-trabecular patient. So this is the ostium, but this ostium is actually not open; it's closed, and very small part is open here. So this also you can see in the angle. Now the other part of the angle you can see here. So this is the angle, and clearly you can see the part. This is the trabecular meshwork, and this is the solvus line. So this way you can actually understand the angle. And when you finish, you very carefully see here, observe here that I'm holding it, then placing pressure in the lower lid, then coming it up. Otherwise, the patient, because of suction action, the patient might get pain. So it's very important to remove the lens. This is another examination by Postner Former gonio lens, and I will do indentation here. So the same kind of thing, but it is the handle. So you can see the position of my little finger here. I'm touching it, fixing my hand, and elbow fixing here. Then I'm just giving a small amount of light in the superior part through this superior mirror, and you can see I am looking the inferior angle here. So very nicely I could see here. But you can see I don't see the stress part or the trabecular meshwork. So that means it is occludable angle. So now I'm giving indentation. And with the indentation, I think you can now recognize the patient's stress part and also the stress part and also the trabecular meshwork. So this patient without indentation was occludable angle. With indentation, I could see all the four angles. So this was a appositional angle closure. And mostly we see this kind of when the patient having early cataract, the patient vision is good, but the apposition angle closure is very common in these cases. This is another patient, not indentation. You can see, cannot see the whole fold structure here, but with indentation you can see. Yes, you can see. So with indentation you can see here the stress part, the trabecular meshwork, Solvay's line. So this is the way of indentation good. So when you can see all structure, you don't need to give indentation, but sometimes to see more clearly the indentation, more bright light, you can do it. Yes, that I was talking, that there is primary testing condition 1, but sometimes when after condition 1 is finished, you can increase the bright illumination to see more structure, better, more pathological changes if you find here. So bright illumination, slit illumination maximum, indentation, many all things you can do. And keep in mind that I can see more pigmentation in the angle, more pigmentation in the Solvay's line. I can see the flex, white flex in the serious explosion syndrome. I can see new vessels. I can see angle recession. I can see pigment collapse in the angle. I can see peripheral anterior synechia. I can see silicon oil. I can see the iris configuration, the double up sign, sine wave sign. So this thing should be kept in mind. Now I'll go to the very important part of the grading, because we always say the grading grade 2, 3, 1, 0 like this. So 2, 3 was person graded the Gonioscopy grading. On his shepherd's grading, space grading, she's grading is not used nowadays. So I'll not talk about this. I'll talk about the shepherds, who is mostly used, and space also. So very important picture here is a book picture. You see that in this grade 4, the angle between the iris and the subretinum is 45 degree. The angle is about 40 to 45 degree, and you can see all the four structures, the four landmarks: the Solvay's line, trabecular meshwork, stress part, and the ciliary body band. So grade 3, 4. I tell if you find 3 structure anteriorly, it's grade 3. Anterior 2 structure, grade 2. Anterior 1 structure, grade 1. There is Solvay's line only. You do not find anything, grade 0. So sometimes we find no structure, there is a grade 0. So angle opening and stress visible depending on this. So this is very important grading. And if we find the structure, you can make the grading yourself. Grading is more important, especially when the insertion of the iris. It is the anterior to the Solvay's line. It's called A. And behind it, it's called B. C is for scratch part, over the scratch part. It deep when the below the behind the in front of this stress part, and extremely deep when 1 meter ciliary body is visible. So this is the way that classified A, B, C, D, E. And another the effects of dynamic peripheral iris contour. Its contour is convex or not? It's convex going anteriorly. It is plateau conversion. That is the sine wave sign, the double hump here and hump here. So this is hump the angle. So the plateau configuration, or it is flat normally, or it is concave, sometimes pigment dispersion. So these are the different way the classification can be done as Spitz showed. Now another thing, how we make a documentation of the gonioscopy and photography. Photography already I have shown you that if you have a camera attached to the slit lamp, all the time you can see that you can take a picture, you can take the video, so you can make a photography like this. But documentation you have to write in the description. How to write? There are many ways you can write, like this circle. The inner circle is represent the stress part, outer is the Solvay's line, and in between is the trabecular meshwork and others. Similarly, you can also make an arrow like this round. And most commonly done is the cross, the right cross for the right eye, cross for the left eye. Very important. And this cross, if you find an angle 0 in all quadrant, you would write like this. If you find posterior treatment at the PTM, treatment superiorly and inferiorly more open sclera part, and say it is the temporal right eye, the temporal, so it is the anterior TM, which is occludable angle, and there is a pass here. So you can write like this. And here again, you can see open angle in 3 quadrant, but ciliary body more open in the other. You can also show like the other eye. So this way you can write, and this is the best way, easiest way to write the angle. This is the easiest way to write. Then I also practice this. Nowadays, I don't have any financial interest because NIDEC GS1, the Gonioscopy machine, gives you the opportunity to take the angle, examine the angle, and take the photograph of the angle. It can take many pictures and then coalesce each other to make a circle. So the whole circular 360-degree angle can be visualized and can be taken photography. And you can analyze any part of this. And suppose this part you can see here, and ultimately circular, you can see what are the changes here. So suppose this is the part, and you can see the hemorrhage here, and this is the part and the hemorrhage here. So this way you can really take a good picture from this machine, NIDEC GS1 Gonioscope machine. You definitely, after when understand the normal physiological findings, we have to look for the pathological findings in examination condition 1 and condition 2. Already I mentioned the peripheral synechiae. It's actually a solid sheet like this is an open angle, but here is the peripheral anterior synechiae, and composed of iris stroma obliterate the angle recess. And it is more common in the primary angle closer glaucoma, anterior eye syndrome, etc. Pigmentary glaucoma is not uncommon. Sometimes you can see the pigments in the angle, pigments in the iris, pigments in the anterior chamber, pigments in the Solbes line, and differs, maybe 1 plus, 2 plus, 3 plus, 4 plus. So you see here it is 4 plus. So this 3 plus, 2 plus, like this. So you can have pigments in different conditions like pigmentary glaucoma, pseudoexpression syndrome, and other conditions. As I mentioned, pseudoexpression glaucoma, also you can see pigments and subflake-like material here in the angle, also in the pupillary margin, you can see here. So this is the other increase anterior angle pigmentation include in some other conditions also. Already I mentioned that when there is high pigmentation and mostly in 360-degree, there is a pigment here, sometimes can be confused with the trabecular meshwork here. But if you look from the eye side, this is the root, this is the sclera part, this is the trabecular meshwork, this is the anterior part of trabecular meshwork, and this is Solbes line, and after that is the line, pigmented line. So this is the anterior pigmented line after the Solbes line is called the symbiosis line. We actually observe it fast. We know that in the trauma, the angle, maybe resist angle, can come from its own place toward the eye. So you can visible the ciliary body is totally visible here. So it is abnormal ciliary body, and it is difference from one corner to one quadrant to another quadrant. So this is very common, and when there is angle recession, the pressure usually goes high. In the long-term uncontrolled diabetic patient or any retinal vein occlusions, ocular syndrome, corneal disease, you can look for any new vessels in the rubeus as a rubeus iris in the iris. And in this case also, you look for any angle in the anterior chamber, in the angle of the anterior chamber. You can see the arborizing the angle is abnormal vessels here and going to over the Solbes line, towards the Solbes line here also. So maybe not in patients with this. Another important part in angle closer glaucoma is the plateau iris. Plateau iris configuration plateau syndrome. Sometimes we find in the gonioscopy, like this, the Humpty Dumpty appearance here, it's normal, but it's elevated area. And if you actually draw the here, you can elevated here and elevated here. And this is called the sine wave sign or double hump, one hump, double hump sign. So when there is if you indent it, if you indent with the 4-mirror gonioscope, you will find here the indentation that causes a dipping in the equator of the lens. So this is a dipping here, and this is the lens, then because the convex surface, and this is the peripheral anterior insertion of the ciliary body that causes another hump. So this is a double hump, and this is found in the iris plateau iris configuration. The syndrome when that after even doing the peripheral iridotomy, the iris condition is not changed. That is called plateau iris syndrome. So another picture of plateau iris configuration and syndrome is that here also is a double hump pattern, and in the UVM it's found more easily that and this is the anterior insertion of the ciliary body, and that actually projecting or pushing the peripheral iris towards the angle, making the angle closer. So this condition is called plateau iris configuration. So after even doing the iridectomy here, this will not change because this is anatomical deformity. It will not be changed. Now I'll ask some quiz. I think our participants, especially, I'll request my residents and students try to understand. You can give it in the chat box. If you can write the answer, just say it here. First of all, this is the patient having a lot of pigmentation in the you can see here the glaucoma short. There's dipping in the mid part of the iris. What can be the diagnosis? Yes, it is the pigment dispersion syndrome. So it can find here. So already in presentation we have shown the flake-like material deposition the angle, also the pupil. What is that? Yes, it is the serious exfoliation syndrome with pigmentation. What about the diagnosis here? You get pigmentation here, and also there's arboration, some iris fibers here. It has gone toward the Stolbi's line. It has gone toward Stolbi's line. It is usually found in the juvenile open-angle glaucoma. Very important. Well, in other picture, I think all of you can understand in the after trauma, it has happened, the angle, what is this? This is the iridodialysis. The whole iris has turned from there, definitely. And it's also a trauma. You can see here, there are a lot of blood here. So what is the diagnosis? Yes, first of all, hyphema is there, angle recession and cyclodialysis. In this video, you can see in the different part of the angle, there is pigmentation here, pigmentation also here, and angle is open. What is your diagnosis? This is the pigmented glaucoma subpilosis line. So I think all of you understand now. So this patient had vitreous surgery only a few months back. In the angle I found this. What is that? Deposition of silicone oil. Well, this patient had glaucoma surgery, trabeculectomy, but the patient is not coming down. And said I do the gonioscopy and I found the peripheral iridectomy is not really a total. A very small area is open, but the whole area is not open. So it is obstructed. So definitely it is the closed ostium. What is the diagnosis here? I think all of us understand this is the eye stem surgery in the angle, the trabecular meshwork. So what is the cause of diagnosis and cause? You can see this is reddish area over the trabecular meshwork. This is the red blood that is seen from the Schlem, coming from Schlem's canal. Why it is come? Blood in the Schlem's canal that is shown as a reddish area in the canal. And ordinarily, Schlem's canal cannot be seen, but in some conditions like elevated scleral episcleral venous pressure in carotid cavernous fistula or Strasbourg syndrome or in hypotony, you can see it. This kind of reddish area, the blood in the Schlem's canal seen over the meshwork. So after this, I think there are some conditions that we should not do. What is the contraindications? Definitely when there is lacerated or perforated wound of eye globe, hyphema, infection, painful inflamed eye, we should not do gonioscopy. And lastly, I would say that the very important part is cleaning. After examination, every patient we should wash it by normal tap water, and then just with some few drops of mild soap moistened with cotton ball, clean it, then rinse it again, and after the disinfection done by 70% isopropyl alcohol most of the time. These are my references. Thank you very much.